Okay, so today we're going to talk about metastatic disease, and this isn't a standalone disease on its own, obviously. But metastasis is probably the most feared word that can be used in the oncology clinic, because everybody has their interpretation of what that means. Metastatic disease, as we previously understood, means that it's no longer just the primary tumor we're talking about. Whether the primary tumor was very small, very large, whether the primary tumor can't even be identified. We have cancer of unknown primary origin. So there are patients that just present to the clinic with metastases. We really have no idea where that primary tumor was. It's gone, it's not there anymore, where it came from, how best to treat it. Metastases means that you're dealing with at least one distant site, probably more. And you can have up to half of patients coming into the clinic that will eventually have metastatic disease. And that becomes a huge problem for treatment because while we have the ability to cure certain types of cancers when they're at an early stage, we do not have the ability to cure metastatic disease. Okay, we can't cure metastatic disease. There's no guarantee that when a patient is stage 4 metastatic disease that we have answers for them that's going to guarantee that this is going to go away. Now, having said that, we can't cure it, but we certainly have patients that can live a very long time with metastatic disease. A lot of that's going to depend on the aggressive nature of their cancer, the heterogeneous nature of their tumor, whether or not that metastatic disease is drug resistant. If they have drug-resistant metastatic disease, we're really running out of options. It also depends on the site of metastases and what type of cancer they have. There are some cancers that are very slow-growing to develop. There's others that are just very aggressive by nature. So there are a lot of factors that go into it. We're only going to talk about 2 drugs, bevacizumab and Avastin, or sorafenib next bar. Sorafenib is new, probably to most of you, but Avastin we discussed in the last lecture because that has a role in colon cancer. So we're going to give a little bit more details today, a little bit more information about bevacizumab, what it is, how it's used. And so these illustrations really highlight the problems for metastatic disease. So on the left side, you have this chart. It says colon cancer. You have a green line and a red line. And the green line represents the years and the cumulative overall survival of those patients with colon cancer. It doesn't give stage, it just says, no mets or mets. So we're dealing with stage 1, 2, or 3 versus stage 4. And then you see the red line really rapidly declining. And so what that illustrates is the fact that with metastatic colorectal cancer, colon cancer, they are less likely to have a good overall survival than those patients with no micrometastases. And it clearly discusses micrometastases because that means that there are metastases there, but we can't detect them. So we can't visualize them. Surgeons are going to do the best job they can. They can't visualize every single micrometastasis. They want to remove as much tumor as they can, and they try to get lesions that are 1 centimeter or larger. But if you have something really tiny, it just doesn't show up. And imaging is not going to pick it up either. So our technology is just not at the stage yet where we can detect these lesions. But that's the whole point of giving chemotherapy, so that the chemotherapy, we follow that up as adjuvant therapy to try to eliminate those micrometastases. We want to eliminate recurrence. We want to try and treat the disease, and we want to prevent metastases because that makes our treatment so much more complicated. And drug-resistant metastases, again, we're really running out of options there. And so you've seen this illustration over here before of stage 4 melanoma. And I put melanoma up because this is from a neural crest origin of cells, and so what that means is it has a propensity to really spread widely throughout the body. So it can go brain, lungs, liver, lymph nodes, small intestine, bone. It can travel to a lot of different sites. And so it's just to illustrate the problem and help you guys understand what the issue is. It's not the primary melanoma on the skin. This can be very, very easily removed. And we have so many treatments now for melanoma. It's trying to deal with a patient, perhaps, that has metastases to one or all of these places. It just becomes so much more difficult. The formation in itself is a multi-step process. It's involved, it's long, it's complex. You have a series of steps, and they all have to be achieved in order for the primary neoplasm to become metastatic. And if we're just comparing these 7 cells up here, only the first cell has the capacity to achieve metastases. All of these others fail at a step, and therefore they're not able to fully develop and colonize at a distant site. So they've done studies in animal models where they inject a number of tumor cells, and what they see is after 24 hours in circulation, there's only 0.01% of all cells that are still there and still detected and still viable. But what they can also do is they can take one cancer stem cell, just one, inject that into an animal, and eventually they will see metastatic tumor growth, meaning it only takes one really nasty, really aggressive cell that is capable of these steps to achieve metastases. So let's just run through the steps here quickly. So you have a primary tumor that's growing out of control for a number of different protein, genetic, and all ways. Eventually you have to develop blood vessels. In order to grow and nourish that tumor, it has to receive oxygen and nutrition from somewhere. Otherwise, it's not going to get more than 10 cells in any direction, diameter, or length. Because at that point, you have necrotic regions of the tumor where they're not getting any nutrition, they're not getting any oxygen. So sometimes when you section or cut through these, they're really nasty. You have areas that are just black and just dead cells, and it smells horrible because you have these regions where they're not getting any blood vessels through there. The process of angiogenesis is important for 2 reasons. If it's going to grow, it has to get into the nutrition, and if it's going to metastasize, it has to either get into the blood system or the lymphatic system, or else it's not going anywhere. It's the difference between one of these cells trying to just crawl its way throughout the body, which is not going to happen in our lifetime, versus it getting into a highway system like the lymphatic vessels or like the blood vessels, so thereby it can travel to distant sites. So it's got to get access, then it's got to detach from the primary tumor and invade into the bloodstream. It has to get into circulation. And this is no trivial matter, because let's think about circulation for a minute. This is a pump going through the heart. There's a lot of things on this highway already. It's more likely these cars are going to get run over and pulverized and shredded the instant they try to get into circulation. So the speculation is, well, how do they survive it all? The speculation is through basically blood clots. And that is why they suggest that the research showing that people that take aspirin and low-dose aspirin, which essentially acts like a blood thinner, will have less risk of metastases because they're eliminating or reducing the possibility of these blood clots or these cancer cells to hitch a ride on, kind of like a surfboard, and get through this really turbulent environment because most cells are shredded. Now, if they survive circulation, they have to get through the heart, then they have to arrest in an organ. They have to adhere to the vessel wall, and then they have extravasation, where they have to actually get through the vessel wall, and then colonize and establish a colony at this distant site, right? They have to have a welcoming party. It can't be a hostile environment. A hostile environment is not going to allow this process to happen. And then, of course, we have the immune system that at any point in time could kick into gear and eliminate this process from happening. So it's incredibly hard to imagine that this happens, but we see this over and over again in the clinic. So the relationship between metastasis and angiogenesis is that angiogenesis has to evolve in order for metastasis through the bloodstream to occur. So here we have a very small localized tumor. It has not metastasized yet. But again, these distant cells, the farther away they get from this blood vessel, they are going to start to secrete factors. As they grow, they need to plug into the oxygen and the nutrition coming in, so they start to secrete factors such as VEGF, which we're going to talk about a lot in this talk. VEGF, the vascular endothelial growth factor. This growth factor literally tells these endothelial cells to start forming tubular-like structures that will eventually become blood vessels. So they're immature blood vessels, and they will connect and hook up to the larger vasculature system, thereby giving access for these tumor cells to get into this pathway. Now, these blood vessels are always chaotic, so it's not nice, regularly shaped, very well laid out patterns of highways in a road system. It's like the most catastrophic road you can imagine. I mean, who did this? This makes absolutely no sense. There is no organization to it. But this is what happens in order for metastasis through the blood system to occur. So in normal situations, you have inhibitors that are at a very high level and activators that are at a very low level. So this is normal right here. This is a normal situation. So essentially, we're looking at a cross-section of what is in the blood vessels or the vasculature. Now, in a situation where you have a more aggressive type of cancer, that's what you're looking at in this scenario. So here we have cancer. And in a cancerous situation, where these cancer cells have started to secrete activators, so they're very high, and then they've also secreted things to inhibit the inhibitors. So the inhibitors are very low, activators are very high, so now we see a lot of these cells gaining access into the vasculature system. So why do we have this system at all, right, in adults? Why do we need this? It's understandable that early embryonic development in children need this vasculature system to grow. And so that's why I put the finger here. So let's think about wound healing. So in wound healing processes, you need this to be able to be regulated and modulated. You need to have the ability to grow cells, proliferate them, seal the wound, get access to the nutrition, the oxygen, and the vasculature system. But cancer cells are taking this normal programming and are hijacking it to their own advantage and their own benefit. And so the whole idea of where do these cells end up? So metastases is not a random event, meaning that a tumor starts on a primary site that just randomly finds its way somewhere. That's not at all what's happening. Stephen Paget proved this in 1889. So he was an English surgeon, and he went through records of 900 autopsies of patients that had cancer. And what he concluded was what became the seed and the soil hypothesis. And that's that metastatic spread is not due to a matter of chance. Tissues are not playing a passive role in this process. Rather, metastasis only happens when the tumor cell acts like the seed and it has a special affinity for a particular type of tissue which provides the soil in order for the growth environment to be sufficient to create the metastatic tumor. So that was the seed and soil hypothesis. Again, the seed is the tumor cell, and the soil is the new tissue in that distant organ. And he came up with this hypothesis again by all the autopsy records he looked at. He said when somebody has prostate cancer, it most likely metastasizes to the bone marrow. That's mainly where it's going to go. And if not the bone marrow, then it's likely to show up in the liver, then with almost equivalent propensity, but to a lesser extent, the brain or the lungs. Compare that to pancreatic cancer. So a patient that has pancreatic cancer, it's highly likely that when that cancer metastasizes, it's going to the liver. This is where you're going to find advanced pancreatic cancer. You may also find it in the lungs, and you can distinguish the difference not by the symbols I put here, but by a beautiful color illustration where they have the width of the arrow. The width of the arrow gives you the propensity or the percent risk that that primary tumor metastasizes to that organ. So again, if we're talking about the pancreas, it's most likely to show up in the liver, but secondarily in the lungs. Breast cancer can metastasize to all four of these sites. It can go to the bone, liver, lungs, or brain, but it's most likely to show up in the bone, and then the lungs, and then the liver, and less so the brain. So maybe like 10% of patients with metastatic breast cancer will have metastases to the brain, so smaller percentage. And then lastly, colon cancer. So colon cancer is our segment into metastatic disease because we talked about this last time. The last slide of my colon cancer lecture said, how are these patients dying? And they are succumbing to metastatic tumors in the liver because when colon cancer metastasizes, this is mainly where it's going. It can also go to the lungs, it can also go to the bone, but it's most likely to be traveling to the liver. Again, the seed is looking for a particular type of soil in which it colonizes. This showed up extremely darkly. Okay, so this is supposed to be a bone, and it's supposed to be in the background. And in front of it, it says extravasation of breast cancer cells into the bone marrow is relatively a permissive process because of the presence of fenestrate sinusoid capillaries. We'll get to the definitions on the next slide. But not just in breast cancer, we also see in prostate cancer and breast cancer, we see a lot of bone metastasis. And so what I have on this slide is how is this treated? And I say treated because we can cross out the word cure. When cancer has metastasized to the bone, there is no cure where we can just start removing, bones in the body to fix this, or we have this drug that's going to attack metastatic tumors in the bones. So we treat this with pain relief. We can't cure it. And so what this is supposed to say is for mild to moderate pain, we can treat this with tramadol. So tramadol has opioid-like side effects, but it's not an opioid, and it can relieve mild to moderate pain. So that's what is here. Hopefully, this is on your slide. Correct? Yes. Yes. No, you can't read it.
The font is white and the background's white, so it's
This came out really poorly. I can turn it on my office here. It looks great, but here, not so much. How about that? Okay, the bone's gone. Okay, so now for mild to moderate pain, tramadol, 100 milligrams. Now for moderate to severe pain, things like intravenous ketorolac, it's a potent non-steroidal anti-inflammatory drug capable of relieving moderate to severe acute bone pain. It's not recommended beyond 5 days for use, however. And obviously, the non-steroidal anti-inflammatory drugs can cause renal insufficiency as well. Opioid analgesics, these are the mainstay for therapy for the treatment of moderate to severe pain or of malignant origin like bone pain. And so here we have oxycodone, morphine, hydrochloroquine, etc. And then we have bisphosphonates and radiotherapy. So there have been multiple studies that have demonstrated efficacy of bisphosphonates in reducing skeletal complication and pain from bone metastases. So this is how we treat. Again, we can't cure it, we can treat it. We have very effective pain medication, and what I'm trying to illustrate here is the CT scan of the vertebrae. So in part A, this is the metastatic involvement at time 0, and then in B, this is 4 months later. And so you see a lot more metastatic involvement in bones. Excruciating pain for patients. But I also want to point out, just to reiterate again, that even though we can't cure this, patients with bone metastases can live a long time with this at a metastatic place. This slide is only meant to be a definition. So here I mentioned the fenestrated sinusoidal capillaries. So here I'm giving a definition of different types of capillaries. So the continuous capillaries, these have a sealed endothelium. And they only allow small molecules like water and ions to diffuse. So this is the kind of endothelium you're likely to see in the brain. And then we have fenestrated capillaries and sinusoidal capillaries. These have very large openings, and this is the point. Red cells, white blood cells, these can easily get through this space. So there's really no problem in a cancer cell getting in and out. So the issue is not, there's not like a physical barrier there that prevents these cancer cells from traveling through there. And so these types of capillaries are found in the liver, in the lymph nodes, and in the bone marrow. But in terms of the continuous capillaries, these are found in the brain. So there's always been this challenge in the treatment of brain metastases because you have the blood-brain barrier. And with the blood-brain barrier, this can be a tumor sanctuary site because the cancer cells are getting in. They're not leaving the gate open. They're getting in, and the gate's closing behind them, but then we can't get the drugs in there to effectively treat these certain types of cancers. And so what you have in the brain is you have the astrocyte wheat that develop a very tight barrier. And then you also have these endothelial cells here. And so with the endothelial cells, these have between them tight junctions. And so tight junctions, it's like having a security force at the gate, right? You're not going to get past it unless you are a specific ion or water that's scheduled to diffuse through. And so this is why I have chemotherapy hanging out here in the vessel, but not within that space because it can't get past the blood-brain barrier. Now, we do have some drugs that are used in glioblastoma multiforme, which you're going to hear about next week. And those can get through the blood-brain barrier. But it certainly becomes a huge complication in treating certain types of cancers when brain metastases has formed. So again, I'm just trying to highlight all of the problems that we have with metastatic cancer. And so I bring up Judah Folkman. He's not super important to this group, and I don't think I've ever really put this on an exam. But the point is that Judah Folkman was one of the first people to start studying angiogenesis inhibitors and then thinking about these as druggable entities. So it's this research that really founded the work that eventually developed the drug bevacizumab. Because Judah Folkman realized that the cancer cells are angiogenesis dependent, so that when you inhibit angiogenesis, then you're not able to grow a tumor like you are in an animal that has a fully functioning repertoire for producing angiogenesis. And I bring the New York Times into this because there was a report on the front page of the health section, May 3rd, 1998, and it said, "Hope in the lab." And it's about Judah Folkman and his research. So I'll just read a little bit of it. It says, "Within a year, if all goes well, the first cancer patient will be injected with 2 new drugs that can eradicate any type of cancer with no obvious side effects and no drug resistance. Some cancer researchers say the drugs are the most exciting treatments that they have ever seen." And then they go on to have a quote by James Watson, right, DNA. And James Watson says, "Judah is going to cure cancer in 2 years." And so we can look back at this as irresponsible journalistic reporting, but certainly there was a lot of excitement at the time in reading this and thinking that if we can only solve the problem of angiogenesis, we can cure cancer. And so again, this is the type of research that led to the invention of bevacizumab. And bevacizumab currently has a lot of approved indications. I know we talked about the drug mascot last time and its role in colon cancer. But in addition to colon cancer, we also see this in non-small cell lung cancer, metastatic renal cell carcinoma, glioblastoma, ovarian cancer, and cervical cancers. Now, it lost its indication for breast cancer. It was approved under the agency's accelerated approval program, the FDA, in 2011. But what they found was that there was absolutely no reduction in tumor growth, tumor size, delayed tumor growth, progression-free survival. There was really nothing there in breast cancer that gave the indication, the deserving merit of having FDA stamp of approval saying this is effective in breast cancer. But of course, to reiterate, it is approved in a number of other cancers. But it was pulled for that indication. And to summarize a lot of the work for bevacizumab, this is a study of colorectal cancer. When treating the control group without it, and then adding it to a regimen of other drugs, colon cancer, you're increasing by about 4 months for the median time to disease progression. So bevacizumab is not typically used as a single agent or monotherapy, but it's added on top of the cytotoxic chemotherapeutic regimens that are used in these indications. So with colorectal cancer, you'll have your FOLFOX or FOLFIRI, and then on top of that, you would have bevacizumab. So it's not a single agent monotherapeutic standalone drug in anything other than maybe a salvage indication for brain cancer. But generally, it's added on top of other regimens. The goal of Avastin therapy is really the first one, not so much the second one. The first one is to reduce the blood supply going to the tumor, starving it of nutrients and oxygen. And the reduction, they inadvertently sensitize tumors, but not so much. It's really you're trying to starve the tumor out. And it does this by being a monoclonal antibody that binds to VEGF. So VEGF is the vascular endothelial growth factor. This enhances angiogenesis by literally telling those endothelial cells to start forming circles and start becoming a new blood vessel so that I can get all the nutrition that I want. And the idea is that you have all these blood vessels and you treat with Avastin to minimize and regress the tumor, and then you have a maintenance of Avastin that sustains this over the long term. However, Avastin has multiple black box warnings. And we talked about some of these last time when I put these on the drug mascot, and that was gastrointestinal perforations, surgery, and wound healing complications. So for this one, it was kind of pointing to epistaxis with that and hemorrhage. I had to pick something to put on the mascot that would make sense. And so with surgery and wound healing complications, patients are suggested to discontinue at least 28 days prior to surgery and not to initiate for at least 28 days after surgery until the wounds are fully healed. Not only is VEGF involved in the formation of blood vessels, it's also involved in hemostasis. So it promotes clotting activity in the blood. So not only does it get new blood vessels, but it also promotes clotting. And so when you're inhibiting these processes, it can be very complicated if we throw in wound healing after surgery. And then also hemorrhage. Severe or fatal hemorrhage, hemoptysis, and gastrointestinal bleeding are major black box warnings. So let's talk about some of these in a little bit more detail. So on the drug mascot, the largest B that I put on that bear was for hypertension. Hypertension develops in 35% of patients receiving bevacizumab, and half of those are at grade 3 or grade 4. And so what do you do if it reaches grade 2 or grade 3? So with grade 2 or grade 3, bevacizumab should be temporarily stopped in patients until the blood pressure levels return to pre-treated values or less than 160 over 100 millimeters of mercury, so standard blood pressure. So to reiterate, you're temporarily stopping patients with grade 2 or grade 3 hypertension. And so when patients are on bevacizumab, they literally have to monitor their blood pressure before, after the first few doses, every 2 weeks, and even when they stop bevacizumab, they're still monitoring their blood pressure for another 6 months. Now, if it's grade 2, not only can you temporarily stop the drug, you're going to give at least one antihypertensive drug. And then if it's grade 3, you can give up to 2 antihypertensive drugs to try to get the hypertension under control so that you can restart bevacizumab.
Question?
Yes?
Is there a reason that they picked that number 160 over 100 because that's still considered hypertension?
It says to pre-treatment values or less than that. They want current antihypertensive drugs to at least maintain a blood pressure of 160 over 100. Now, the difference between chemotherapy and targeted therapy is you're not looking at a dose reduction or a dose modification. You're looking at a cessation of the drug. With proteinuria, similar in the sense that if it's grade 1, there's no change. But if it's grade 2 or grade 3, the recommendations are to withhold Avastin. Now, similar to hypertension, which I did not say, but if it's grade 4, you are going to permanently discontinue the drug. If it's hypertension grade 4, if it's proteinuria grade 4, you permanently discontinue the drug. Thromboembolic events are another concern. I have on here venous thromboembolism, but also arterial thromboembolic events. And so on the drug mascot, this is why I had to pick one, and so I picked myocardial infarction. And so that's what's on the mascot to represent the thromboembolic events that are a major complication for bevacizumab. And so here are the recommendations for this as well. So I'm just going to go through these quickly. So again, notice that there are no recommendations for dose reductions in a setting of adverse events. You're discontinuing or you're temporarily interrupting administration of this drug. And then, of course, wound healing. We have the recommendations on the black box, as well as here, as to not starting bevacizumab until 28 days after surgery. Now we're going to move on to the next phase of this lecture, and that is hepatocellular carcinoma. And the reason why I pair liver with this is because it comes right after colon cancer, and also because liver being a major site for metastatic cancer. So liver has a number of different functions. For this audience, the metabolism of drugs is incredibly important, so the liver has all kinds of enzymes. Now the treatment complications include liver cirrhosis. So patients presenting to the clinic with hepatocellular carcinoma are already experiencing some level of liver cirrhosis. And liver cirrhosis is important because that obviously impacts the body's ability greatly to metabolize drugs. The liver is also filled with, as you guys know, all kinds of enzymes to break drugs down. So truly cytotoxic chemotherapy is just not effective when you're trying to go after hepatocellular carcinoma. So cytotoxic chemotherapy, tried clinical trials, everything is a failure. You're going to see some of the slides here about some of the failures as well. So the etiology is that you can start with some type of viral indication, maybe hepatitis B or C chronic infection of the liver. Eventually cirrhosis develops, and you have phenotypically altered hepatocytes or liver cells. Then you have dysplasia, and then you can develop hepatocellular carcinoma. So these lesions here with the white arrows are exemplifying what exactly this looks like in the mouse liver. Now, liver cancer is common worldwide. I kind of got ahead of myself here. It's not necessarily the most common. It is a common cancer worldwide. But it's the third leading cause of cancer-related mortality worldwide. So again, it's not the most, but it is common. And that arises from things like hepatitis infection, chronic infection with hepatitis B or C. And it also makes it very difficult to treat. And if we look at worldwide cases, again, we see less than about 20,000 in the U.S. So liver cancer is not a major cancer that we see in the United States, although it's on the rise. But globally, it's a huge problem. And that can be due to not only hepatitis, but the fact that in certain parts of the world, you have aflatoxins. And aflatoxins are a hepatocarcinogen is a dietary exposure. So these are mycotoxins produced by Aspergillus species in hot and humid environments, and they get into contaminate grain and peanuts and corn and rice. And so this is what leads to the development of hepatocellular carcinoma at really high rates in certain parts of the globe. Now, in order to assess cirrhosis of the liver, we have scoring systems. One of those being the Child Health Scoring System for liver cirrhosis, where you're really looking at the liver's ability to perform its function.